Good evening.
Good evening, sir.
Can I start? Can you see my screen?
Yes, sir.
So, shall we start? Hello? I will start now. Good evening once again. Are you there? Everybody is listening? Hearing me? Hello?
Yes, sir.
Yes, we can hear.
Yes, sir.
I'll start. Okay. So, in part 2, we'll deal with it's not working. Okay. We'll deal with the diabetic macular edema, investigations, treatment of diabetic retinopathy, diabetic macular edema, PDR and its complications, and we'll see whether we can cover prognosis. Coming to diabetic macular edema, is defined as retinal thickening or hard exudates, or both may be there, at or within 1 disc diameter from the center of the macula. So draw a 1 disc diameter here, 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 everywhere. So if it is there within 1 disc diameter of the center of the macula, we call it as diabetic macular edema. Please note that it can be present in non-proliferative type as well as in proliferative type. Okay, so you can see in these pictures it is non-proliferative and proliferative. In both it can be there. So how do you detect it clinically? We do slit lamp biomicroscopic fundus examination with 90 diopter or contact lens examination. This gives a stereoscopic view of the macula. So what we should look for, there will be loss of foveal reflex if the fovea is involved, or there is area of retinal thickening and we should note its extent. There may be cystoid changes if we look carefully and play with our the slit lamp light. And we can even detect subretinal fluid as gentle elevation of the retina over some area with loss of choroidal pattern under it. DME is classified clinically as clinically significant macular edema and not clinically significant macular edema even when it is present. So what is clinically significant macular edema? There are 3 definitions for this. The first definition is there is retinal thickening or edema within the 500 micron of the center of the fovea. That is the first definition. The second is there is hard exudate in the within 500 micron from the center of the fovea, but there is no thickness in that 500 micron, but there is adjacent thickening outside that 500 micron. The third definition, there is a large area of retinal thickening, which is about 1 disc diameter or more, and some part of which lies within the area which is about 1 disc diameter from the center of the fovea. So all these 3 definitions were enumerated in early treatment diabetic retinopathy study, a randomized control study, and they were used till almost recently. By fluorescein angiogram, we classify it as focal, diffuse, and ischemic. And in fact, note that this article says that this usage of these terms is so vague, it may probably be dropped. But anyway, we'll complete because many people do ask. And okay. The focal is actually localized area of retinal thickening, usually in the form of few hard exudate rings, and there are microorganisms in the center of those hard exudate rings. We saw that in the when we were studying about hard exudates. And if you do fluorescein angiogram, those microorganisms in the center show leakage. So like this, in this patient, there are few microorganisms and few hard exudates. And if you do fluorescein angiogram, there are focal areas of leakage, but there is no diffuse leakage. Now, what is diffuse? Diffuse is this another example of succinate retinopathy with focal edema of focal diabetic macular edema. The diffuse is there is retinal thickening covering large area with very few microorganisms. And fundus fluorescent angiogram shows that the leakage mainly comes from dilated capillaries and less from microorganisms. Actually, we may not be able to see where the leakage comes from. And we may be able to see cystoid changes. As in this case, actually there are hardly few hard exudates and all, but there is diffuse leakage here. And this is a late picture which shows cystoid flower petal appearance, which shows cystoid macular edema in the macula. And this is another area where there is a increase. This is ischemic maculopathy. So this patient has actually a very indiscript macula. You cannot see much except that the foveal reflex is lost and his vision is less. So how do you explain the vision? We do fluorescent angiogram. We come to know that his foveal avascular zone, which should be less than 500 microns, is almost, actually it is bigger than the disc. So that's about 1500 microns. Now, the diabetic macular edema is also classified by clinical studies. Recently, this is the classification they're using, whether it is center involving or non-center involving. What is center involving DME? It's actually OCT thickness of 250, more than 250 micron in the central subfield of time domain OCT or any OCT for that matter. The central subfield has 1 millimeter diameter. So what is that central subfield? So if this is the OCT picture, so there are 3 circles in this picture. The central circle has 1 millimeter diameter, the middle circle has 3 millimeter diameter, and the outer circle has 6 millimeter diameter. What we are concentrating is in this 1 millimeter diameter circle, and this is called central subfoveal thickness. How do you get 250 micron in the studies? This is a stratus OCT, what they were using. The normal upper limit was 212 with a standard deviation of 19. The average was 212. The standard deviation was 19. So if it takes 2 standard deviation, it becomes 250. So anything above 250, they say that it is abnormal. But if you see other machines, there are different values. So you have to calculate the value for your machine, whatever machine you are using in your hospital. So again, center involving edema, you can see that the figure is shown actually 580 micron. It should be less than 280 or so. And you can also see here, the central subfoveal is not at one point. It's actually over a period, over a region of 1 millimeter, as I have shown with yellow lines with 1 millimeter marking made in that. I hope you all not understood. So this example of diabetic macular edema, which is not center involving. See that the center is not thickened, its thickness is not more than 250 micron. Whereas in this case, the center is definitely thick and it is more than 250 micron. As you can see in this small pink circle, it is pink, not green. If it is green, it is normal. So what investigations we do for diabetic retinopathy? We do general investigations like FBS, HbA1c, just to assess the control and blood pressure. And there are some specific investigations we'll study. When should we do fluorescent angiogram? Actually, routine use of fluorescent angiogram in all cases of diabetic retinopathy and DME has reduced with the introduction of OCT and anti-VEGF treatments. When we want to do focal laser or grid laser treatment for CSME, it's probably wise to do a fluorescent angiogram so that you can identify leakage points and apply laser. And do fluorescent angiogram where ischemic maculopathy is suspected, because visual acuity will be poor, but fundus findings do not match, so we are confused. So in such cases, we do. So this is the focal edema, we saw that. And this is the macular ischemia where the vision cannot be explained by the fundus findings. But when we do fluorescent angiogram, you can see that there is a very large area of foveal vascular zone. Now, the OCT is very important investigation in diabetic macular edema. It plays a very great role in diagnosis, decision of treatment, follow-up and prognostication of DME. So what are the advantages? It is non-invasive and it's very quick. It is finished in 2 to 5 minutes. And it objectively measures thickness of the retina in the foveal subfield field area. So when we do follow-up after treatment, we can see whether the thickness has come down or not. It's not subjective. We are not telling it's reduced or increased. The machine gives exact figures. Actually, it is an in vivo optical biopsy. We can detect cystoid changes, SRF, fractional changes, and so many other important lines it can delineate. So it's a very important tool. It's a great educational tool to motivate the patients to accept the treatment and control the diabetics. And of course, it's a teaching tool for the students. So this is how the OCT output comes. This thickness in each quadrant. This is the average thickness. A lot of scans are done in 1 millimeter as well as all in others. So that average thickness in each field is given. And actually in the central 6 millimeter, it also gives the total volume of the retina. So we can compare it with normal values and say there is edema or not. Now, if you do OCT, the types of DME they are classified as diffuse, cystoid, subretinal fluid, and mixed. Most of the times it is mixed. There is not one variety will not be predominating, but usually it is mixed. And there is also another element called tractional and epiphyseal membranes. The characteristic lesions are hard exudates and hemorrhages. They are actually hyperreflective, so they appear white. And intraretinal edema, cystoid spaces, and subretinal fluid, they are hyporeflective, so they appear dark black. And shadow effect is seen in hard exudate vessels and hemorrhages. We'll see some example. So this is an example of diffuse edema. You can see that the whole retina is swollen as though you have put water in tissue paper, it has swollen up. And there are hardly any cystoid spaces, and there are some hard exudates. So this is example of diffuse, as well as there are some areas of cystoid. You can see the cystoid spaces. You can also see the hard exudates causing shadowing. This is called shadowing, and they are red actually, so they are hyperreflective. Whereas the darker areas are the cyst. You can see one more cyst here. And also notice that the posterior hyaloid has detached in perifoveally, but not over the fovea. It is still attached over the fovea. And this is another example of cystoid, as well as diffuse, as well as subretinal fluid. Can you see the elevation of neurosensory retina from the RPE? So there are examples of everything. The cystoid spaces appear darker, and there is actually shadowing by the hard exudates. So now, what is those important lines? This is another example of diffuse edema. We'll come to that. The diffuse edema, you can see, actually you don't see many cystoid spaces, but actually you are also seeing a subretinal fluid in this. So this is very common in diabetic retinopathy, and especially common in patients who are having renal issues. So this how it helps. Just see this. This was in 13th May 2010. There is diffuse edema. You can see some hard exudates. We treated with anti-VEGF. You can see the edema has come down a lot, but the hard exudates are more because as though you have squeezed some fluid and the solid part has come out. Now see, we followed him up further in April. You can see the hard exudates have come down and the edema has come down. And in September 2011, everything has gone after the rigorous treatment, the anti-VEGF treatment. Another example, so you can objectively see that there are cystoid changes. Clinically, you may not be able to make the difference between these two, but the OCT shows the difference very clearly that the edema is reduced. What is tractional maculopathy? You can see that there is a thick membrane over the disc pulling the retina here, and you can also see some fibers going here, and you can see probably there is a macular hole or some sort of changes. And when we do OCT, it shows that it's not macular hole, actually it is a partial thickness macular hole. And you can see that the retina has undergone schisis here. Actually, there are lots of schitic changes as well as some cystoid changes. A thick apparatal membrane, very adherent to the retina, and there are some changes in the deeper retinal level. So giving a prognosis that even if you remove this apparatal membrane, he may not improve visual acuity much. So the prognostic factors are, if there is disturbed ELM, the external limiting membrane ellipsoid zone, I'll come to that, what are those? And cystoid spaces are more in number and their size is more. And deranged retinal inner layer sign called as drill sign if it is present. And retinal thickness, as per se, they say it is not that prognostic, it doesn't have that much prognostic value. And RP atrophy is a very important sign. So now we'll come to the 4 important lines I was telling. So they are all in the outer retina. The first very prominent line is the external limiting membrane. You can all see this. All of you can see this. The first line. This is the vitreous. This is the internal limiting membrane. When you come to the retina, this is the first bright line is the external limiting membrane. Okay. Now the second bright line.
Yes, sir.
Okay. The second bright line which follows from here and raises a little is the ellipsoid zone. Can you all see this ellipsoid zone? Very important. And the next line, you can see one thin white line here. Can you all see this? Sometimes it is.
Yes, sir.
Yes. This is actually called as cost line, cone outer segment tip sign, or cone pigment epithelium interdigitation zone. And the last bright line is the RP. Okay. So these 4 lines are very important, especially the external limiting membrane as well as the ellipsoid zone. So you can see in this case, there are hard exudates right in the center, and though there is external limiting membrane, the ellipsoid zone has gone. Actually, ellipsoid zone is outer photosegment receptors, so they are gone. So probably this patient will have poor vision. This one. You can also see here. Actually, the structure is so much lost. You cannot make out external limiting membrane. You cannot make out the ellipsoid zone. And in this case, you can see that actually, if we go back a few pictures. Can you see this? This is the inner retina. You can see the nerve fiber layer, ganglion cell layer. This is the inner plexiform layer. This is the inner nuclear layer, and this is the outer plexiform layer. So that inner layer, the quality of retina is seen, but that is lost here. You can see that you cannot make out those layers apart from the disturbance with ellipsoid zone here in the center, and there is a epiretinal membrane here. So this is called deranged retinal inner layer or drill sign, and this also has been reported as a bad prognostic sign. Now there is OCT angiography. I will not deal much with that. Actually, it's not available everywhere. Just to suffice that it does not detect microisms in all the cases, only about 67%. It does not detect leakage if there is diffuse edema. Of course, it detects foveal vascular zone, and it's limited only to 3 to 6 millimeter in the center. Advantage is non-invasive, so we need not give injections. So patients with renal issues and all, we can do this test instead of fluorescein angiogram. There is another edition called ultra-wide field fundus photography and fluorescein angiogram, where you can get actually nasal to temporal retina almost 200 degree versus only 60 degree we get in our fluorescein angiogram instruments. This is produced by Optos from Ireland, and you can image about 82% of the retina. Advantages are when you do fluorescein angiogram with this, we can detect dropout areas in the periphery, which is very, it's not possible with the existing this one. So this is a photograph from Indian Journal of Ophthalmology. You can see that this is the laser marks. You can see this is the macula, and you can see some NV leaking here, small NV leaking here, and there are a lot of dropout areas in the periphery. Can you see here? There is no capillary networks here. So this peripheral pathology can be seen. Now, sometimes you have to do ultrasound. The investigation is necessary when there is cataract, there is no view of the fundus, and we suspect that patient has diabetic retinopathy. And patient has, especially when there is NVA and NVA with the cataract, and there is vitreous hemorrhage, and we cannot see the fundus retina. So we, in these cases, we do and diagnose vitreous hemorrhage, RD, TRD, or PVD. So this is an example where a tractional RD is there. You can see this is the band of vitreous, the posterior hyaloid, which is pulling up the retina here, and retina is tented up here. So this is the classical tractional RD. Now we'll start the treatment of diabetic macular edema, diabetic retinopathy, and PDR. So I will just go the treatment of diabetic macular edema on an evidence-based medicine. So before that, we should tell that the patient should control diabetes and other risk factors like blood pressure. And you should also ask patients if they are taking pioglitazone or rosiglitazone, because they are known to worsen DME. And if patient has DME, better stop them and change to other drugs with the help of physician. The modalities of treatment for diabetic macular edema are oral medications, laser photocoagulation, anti-VEGF injections, and steroids. Oral medication fenofibrate was shown to be effective in reducing the need for laser in a study published in Lancet, but however it lacks very slowly, and not many of the ophthalmologists use this medicine. Now the first randomized control study, the evidence-based medicine, comes from this study, which was conducted in the 80s. So what they did was they took clinically significant macular edema. They divided into two groups. Pay attention to this chart. One group they did not treat by laser, another group they treated. They also took macular edema, but without clinically significant macular edema, and they also treated one group without laser and one group with laser. So what they found was at the end of 2 years or 3 years, what they found was, you can see that the patients who were treated by laser, they had less chance of losing vision. So it was reduced by 50%. Those who were given, were observed, they had more likelihood of losing vision. But this difference was not found in patients with not clinically significant macular edema. So, and they treated eyes with CSME, and vision of those patients varied from 2015, that means 6/4 to 660. So the conclusion was very clear that if patient has CSME and in respect to the vision, you treat by laser. So this is an example of a patient who has a macular edema here. There are cystoid changes in the OCT. You can see some small hard exudate and few micronisms here. And actually her vision was 6 partial actually. And I did laser for her, and you can see that though there is some cystoid space, the hard exudate which is seen here has gone actually, and she is much better and 6/6 vision. So this is the importance of treatment of focal laser. So focal laser, there are two treatments. One is focal and another is modified grid. Focal is done when there is localized edema, like the case I showed you. There are only few micronisms, and we do that. Modified grid is when there is diffuse area of edema, and we have to treat all that area by applying burns, laser burns in the edematous area, along with the treatment of micronisms if they are visible. Now, what are the laser parameters of focal laser, grid laser? I think exam going students should know this. For focal laser, we of course give topical anesthesia consent. We use Mainster standard lens or high mag lens, And laser burns are applied to the microorganisms so that they just blanch, mild blanch, not very white burns. The spot size is usually between 50 to 100 microns. Power is used between 50 to 100 microns. So we can titrate the power to get the required reaction. Duration of laser is 0.05 seconds to 0.1 second. And all microorganisms outside the 500 micron foveal center are treated. We do not go within 500 micron center unless it is retreatment. But regarding modified grid laser, which is diffuse edema, we treat all the edematous area with 50 to 200 micron spot size, depending on the area and how close it is to the macula. Power used is 50 to 100. We can increase it to get little more burn. Duration of laser is 0.1 second, and laser is applied one burn width apart in the edematous area. And this laser is not applied to any microorganisms. We may not be able to see. So it is applied at the RP level, and we just get a small, very mild white blanching of the RP. The central 1 millimeter is avoided, and papulomacular bundle is avoided. So this is how the laser burn, these black burns are the laser burns. So this is called as modified grid photocoagulation. What are the disadvantages of laser? Though the risk of visual loss is reduced, the visual gain is very less. And if you do microperimetry, there are field defects, contrast sensitivity decreases, and laser scars enlarge and may encroach on the fovea. Sometimes accidental burn to the fovea can occur. So this, you can see that there are so many focal laser burns. These are all before anti-VEGFs came. So that was the only treatments. Every time patient walks in, you do some laser. So you get, he has so many laser marks, he will have a visual field defects, and see how these laser marks are enlarged over a period of time. So anything better? There was a search for better alternatives, and anti-VEGFs made entry in 2005 for cancer treatment, and the company modified the molecule Avastin into ranibizumab, and they conducted rise and ride trial for diabetic macular edema. These are randomized controlled trials, and it was approved for diabetic macular edema treatment by FDA in 2012. Now, so the evidence-based guidelines are, so when should we treat anti-VEGF? When should we use anti-VEGF for DME? If there is center involving DME. So you can see that in all these trials, this term is used, center involving DME. That is where the central subfield 1 millimeter shows thickness, average thickness of more than 250 micron. That is number one. And their vision is not 6 by 6 or 6 by 7.5, but has to be 6 by 9 or worse than that. And up to 696 means more than 660 actually. And it was shown that anti-VEGF is better than laser treatment in such cases because they gain an average of 8 letters, and laser eyes, treated eyes actually lose 1 letter over a period of 2 to 3 years. But the problem is they need 7 to 9 injections in the first year to get this benefit of 8 injections. So it was concluded that anti-VEGF treatment for DME is better than laser in the patients with above characteristics. We told about the characteristics. Now these are the molecules I discussed that during the ROP, this one. So this is one patient where the patient came with this edema, and she received monthly injections for 3. And you can see that this was in April, this is in September. You can see that the edema has come down, the cystoid spaces are less. You can also see that the hard exudates, can you all appreciate? Hard exudates are much less here after about 3 injections of Avastin. Actually, ranibizumab we gave. But anyway, question remained. All anti-VEGF trials have excluded these good vision eyes, but EDTRS included good vision eyes. So one can ask whether center involving DME with visual acuity of 6 by 6 or 6.7.5, can they give anti-VEGF instead of laser? And actually they did study for that. It's called Protocol V study, and they published the results, and they told that it is, if the vision is better and there is center involving DME, it is not good to give any anti-VEGF. Observation is better option, because there is the loss of letters was equal among all the patients. So now we'll come to a flow chart. So how do I move this? Okay. Okay. See, if there is diabetic macular edema, classify them whether it is center involving or not center involving. So DME, so OCT is a must. Now there is no center involving this one, so anti-VEGF do not come into play. And if there is no center involving, but still CSME present, because one of these definitions, the other 2 definitions may be met. If it is there, irrespective of the vision, you treat by focal laser according to ETDRS study. Now, suppose there is OCT shows that the center is involved. Now you classify further into whether the vision is 6 by 9 or better, or 6 by 9 or worse. Sorry, worse than 6 by 9 or 6 by 9 or worse. If it is better than 6 by 9, then better observe that till it worsens, or it improves spontaneously if he controls blood pressure and sugar. Suppose it is 6/9 or worse, then anti-VEGF treatment is the best. Okay, you start anti-VEGF treatment. Now you may ask, what are the advantages and disadvantages of anti-VEGF? So one advantage is we saw vision improves. It reduces central foveal thickness. One more very important advantage is the severity of the diabetic retinopathy goes. So we are treating DME, but is diabetic retinopathy from severe, it may become mild. And also the chances of developing PDR become very less. The disadvantages are repeated injections, many visits, cost, risk of endophthalmitis, vitreous hemorrhage, cataract and RD are there, though they are small. And there are some systemic considerations. In fact, we published a paper of incidence of endophthalmitis after bevacizumab injection. Almost 1 in 800 patients developed endophthalmitis. Now, which anti-VEGF to use? So actually a study, there is a randomized control study to tell which is better. So they used aflibercept, bevacizumab and ranibizumab in 3 groups of patients. And the criteria were the same. 20/30 or worse vision and central subfoveal thickness of 250 micron or more in center involving edema. At the end of 2 years, they declared that the results were similar. But of course, at the end of first year, aflibercept was better than, so you can see aflibercept gained 13.3 letters compared to others, bevacizumab and ranibizumab, which was less. So it was superior, but at the end of 2 years, you can see that they were all having almost similar visual acuity. So we should use the costlier drug, aflibercept and ranibizumab, or the bevacizumab. The cost analysis, cost-benefit analysis shows that actually bevacizumab equal to ranibizumab, aflibercept if you take cost. Actually, bevacizumab is not approved by FDA and it is used off-label by all the ophthalmologists. Now, how do you start the treatment with anti-VEGF and how long you continue? Actually, initially when we diagnose DME, we start injections every month for 3 months. And after 3 injections, we have 2 options, either PRN or treat and extend. What is PRN? Pro ra nata. This is an, I think, Roman or Greek word. It means as needed. So every month we check the patient for visual acuity and OCT. And if there is change, means if it is increased, we give injection and call next month. Now we stop injection in any month. When the patient comes, if the vision is good and the OCT is stabilized, then we call him next month. If it has worsened, we again start injection. So that is called as needed. But the patient has to visit the clinic every month. That is the disadvantage. Now treat and extend is after 3 to 6 months of the vision becomes stable. We check him if the vision has become stable. And at that time we give injection. And instead of 1 month, we call him at 6 weeks. And after 6 weeks when he comes, we again check visual acuity and OCT. And if it is stable, we still give injection. Note that. We still give injection and call him after 8 weeks. So after 8 weeks, if he's still stable, we call him after 10 weeks. So it goes on till we extend the interval between the 2 visits to 4 months. So by this, we reduce the visits. But anyway, during any of the visits, if the visual acuity has worsened or OCT has worsened, then patient has to go back to monthly injection. Oh my God, what is this? So this is almost the same. Now treatment of DME, you have to be very careful. It can be frustrating. It recurs back in 50% of the cases. Good counseling is needed from the beginning. Switching to other anti-VEGFs or steroids can be done if response is not optimal. So when do you use steroids or when do you switch to steroids? If anti-VEGF treatment is failure, what is it? Loss of 10 letters or more after at least 4 anti-VEGF injections, or after 1 year of treatment with anti-VEGF, there is no improvement at all in visual acuity or OCT. Or patient is not compliant in treatment because he cannot come every month. Or sometimes if there is recent MI or stroke, they are not eligible to receive anti-VEGFs. So in such cases, you can give steroids and even pregnant women also. So this patient actually, after 3 months, she developed heart attack. Actually, we give steroid dexamethasone depot. You can see the depot here. Now, what are the available steroids? Triamcinolone, acetonide, or tricot, or Kenalog, whatever it is. Its dose is 1 to 4 milligram given intravitreally. Some people give post-subfield also, but it's not. It is cheap but not effective. More effective than laser. So I have stopped it using. Many people don't stop using. It causes cataract and glaucoma very commonly. But the more commonly used are dexamethasone implant called as Ozurdex, which costs about 28,000 rupees, and it's approved by FDA for DME. And fluocinolone acetonide, which is not available in India, it's called Illuvion. It's approved by FDA in America and other things. So a study showed that the laser is superior to intravitreal injection triamcinolone. So most of the people don't use, except a subset of patients with pseudophakia because they don't have cataract, so they may not. They may develop glaucoma still. Now coming to Ozurdex or Illuvion, you may or may not remember, it's not available in India. Just see Ozurdex, after 3 years, the patients gain about 3.5 to 4 letters, and the about 22% improve visual acuity by 15 letters or more. And one good thing is they needed only 4 injections over a period of 3 years. But the flip side is cataract in 60% and glaucoma needing medication in about 41%. Whereas these are much higher in case of Iluvien. But the advantage of Iluvien is one injection effect lasts for 1 year. That is the best advantage. Now, when to choose Ozurdex for the center involving DME? As a primary therapy. So from the beginning, we want to give Ozurdex. These are the patients who refuse anti-VEGFs because they cannot come every month, or patients who have some heart issues and other things, or pseudophakic patients with no glaucoma. You can choose that so that you can reduce examination frequencies. And patients who have diabetic macular edema for more than 3 years and have not received any treatment, so better to give them. And for pregnant women, anti-VEGFs are not advisable, so we can give them. As a secondary therapy, we can give them to patients who are not responding to anti-VEGF treatment. The advantages I told you, Ozurdex lasts for 3 to 4 months, Iluvien lasts for up to 36 months. So the treatment burden reduces, cost reduce. They are effective in chronic edema. Systemic side effects are not a concern, but of course, they have the disadvantage of increased IOP, cataract, and sometimes intraocular steroids can and exacerbate or actually elicit CME retinitis and ERN because local immunity is reduced, so they may develop some ocular infections. So a study examined whether we can give both anti-VEGF and steroid. It's called protocol use study. It said it's of no use, so don't combine. Now, can we do Parsmana vitrectomy with ILM peeling for DME? It's a major surgery with risks, and results are not consistent. So it is kept as a last resort when they are not responding to any treatment. So this is a patient in Kuwait. You can see that he, over a period of 3 years, he received about 10 injections, and he is doing much better than before. But they need a lot of injection. Now we'll come to treatment of PDR. The treatment is carried out. In case I go off, again sign in, please. I don't know, I thought I'll be finishing early. So please sign in, okay? Are you there with me? So for proliferative diabetic retinopathy, treatment is carried out usually at the stage of high risk characteristic PDR. We saw what is high risk characteristic PDR, but we can start earlier if patient's follow-up is questionable, or he is one-eyed, he has lost the other eye due to proliferative diabetic retinopathy, he's old. So some of the considerations you can take. So the diabetic retinopathy study was conducted somewhere in 70s. They showed that if you treat eyes with high-risk characteristic PDR by pan-retinal photocoagulation, which is called PRPC, the risk of severe visual loss is reduced by 50%. So since then it has become gold standard. So suppose a patient has NVD vitreous hemorrhage, if you don't treat, 26% will lose severe visual loss. But if you treat only, it is 4%. So the effects are very dramatic. So how to do? Of course, take consent and other things. Usually we do on slit lamp or indirect laser ophthalmoscope. We use main stir wide field lens or 165-degree lens. The spot size can be anywhere from 200 to 500 micron. Duration of laser is about 0.1 second. Power you can start from 200 milliwatts and you can increase. If there is cataract, you have to use more power. If it is pseudophakic, less power. The whole procedure is done in 3 to 4 settings. We start inferiorly so that if there is any vitreous hemorrhage, it will clear last from the inferior area. So we want to finish the inferior area first. We usually start 1 disc diameter away from the disc nasally and 2 disc diameter away from the fovea temporally. And we start from outside the arcade. All the retina way up to the equator or beyond is covered by laser burns in 3 to 4 settings. And burns are placed about 1 burn width apart. Usually about 1500 spots are needed per sitting if 200 micron size is used, but if you are using a bigger one, you may cover the retinal area in lesser number of spots. We do additional laser sittings if we see that there is no regression of the NV or there is recurrence. So this is the example of, all of you can see this photograph. These small white spots are the laser marks actually. So you can see that they are left 1 disc diameter here and about 2 to 3 disc diameters from the fovea, and they are started just outside the arcade. So they are gone way up to the equator or beyond if possible, okay? So cover as much retina as possible. So we are destroying all the hypoxic retina so that it stops producing VEGF. VEGF is the stimulus for producing new vessels. Now, what are the signs of regression? The new vessels shrink and they fibrose. The venous dilatation reduces. Hemorrhages, microaneurysms reduce. they may develop disc pallor, and laser scars develop into pigmented and some atrophic scars. You can see this patient, this was in actually 99, and you can see some new vessels are there, a small bleed is there, you can see some hemorrhages, and there are actually already some laser spots. Underwent some more laser spots, and it was in after 1 year, you can see the new vessels have fibrosed, and there are hardly any hemorrhages. You can see the scar, and disc is little paler than before. So it's good regression. Now, what are the complications of PRPC? Corneal abrasions, worsening of DME. This is very important. The DME can worsen in these patients. You have to caution. Actually, vision may reduce. That's especially true in the type 2 diabetes. The choroidal detachment, hypotony if extensive PRPC is done, they may develop choroidal detachment and hypotony. Vitreous hemorrhage can occur because it induces fibrosis. Fibrosis pulls off the retinal vessels. TRD, if there is some TRD there, it may increase because the contraction starts. And peripheral field constriction is very important. About 15-degree field is lost due to PRPC, disc pallor, and pupillary atrophy. There are so many others, but these are the main ones. Now, because VEGF is known to promote neovascularization, and anti-VEGF will arrest that process. So it was natural that they started using anti-VEGF for PDR. And actually, the protocol S study from America, they compared ranibizumab injection with PRPC. Hello? Hello? Are you there?
Yes, sir.
Okay. For high-risk PDR, they excluded, of course, eyes with TRD, they cannot do. So what they found that after 2 years, the ranibizumab, that's anti-VEGF, was better than PRPC in eyes with PDR in terms of the visual field loss was less. Then there was less need for vitrectomy surgery. And of course, because ranibizumab is treatment for DME, these patients developed less DME than patients who had PRPC. And final visual acuity results were, of course, both were same in the both groups, but there are some advantages. The problem is, this one case in we had given, you can see this NVIDIA, and you give Avastin, see how it regresses within 15 days, actually it becomes fibrosed. Now, what are the advantages? There's a good debate actually for the PG students. You can have a debate, one mock debate on Zoom. So what are advantages and disadvantages? In PREP, we have to take in 3 to 4 sittings, whereas ranibizumab needs 7 injections at least in the first year. It is a destructive procedure. Ranibizumab is not a destructive procedure. It is less costly. Whereas the ranibizumab is more costly. PRP is non-invasive. Ranibizumab is invasive. There is no endophthalmitis, but endophthalmitis RD are possible. Peripheral field is lost in PRPP, whereas it's not lost in this one. Dark adaptation will be reduced. It's not affected in ranibizumab. DME worsens in PRP, but not so in ranibizumab group or anti-VEGF group. PPV needs more patients need, they have less patients need. But one important thing, long-term follow-up need not be very rigorous with PRP if you have done complete PRP and there is regression, but long-term follow-up is needed because after we stop anti-VEGF, the hypoxic retina again starts producing VEGF and they may develop fibrosis. Actually, there are papers from protocol A study where they lost to follow-up and they came back with very bad TRD. And there is